Okay, so today we want to talk about host responses of tumors, paraneoplastic syndromes, grading and staging of malignant tumors. Okay, so we want to start with host responses of tumors, grading and staging of malignant tumors. So um, I think initially I talked about malignant and benign tumors, right? And we talked about the differences between the two of them. Okay. So malignant and benign tumors may cause problems because of location and impingement on adjustment structures. In short, they can have local inversion, okay? Then you can have functional activities such as hormones, synthesis, and development of paraneoplastic syndromes. Maybe if I can elaborate this one, you guys know about things like the adenomas, like we can have an insulinoma, which is a tumor or an adenoma of the beta cells of the pancreas. So in case you have this tumor, we'll have increased production of hormones, okay? And again, I hope you know that it is benign tumors that can actually assume the functions of the normal glands. For example, when you have a thyroid gland adenoma, it can still produce thyroxine, but in copious amounts, okay? So the same thing can be seen here, where we can have a tumor of maybe the beta cells of the pancreas or even the alpha cells, which will lead to increased production of insulin and glucagon respectively. So again, we can have bleeding and infections when the tumor ulcerates from adjacent surfaces, okay? We can have bleeding because basically an ulceration will lead to bleeding. That is quite obvious. Then you can have even symptoms that result from rupture or maybe infarction, okay? Then you can have cachexia or wasting. About cachexia and wasting, we'll talk about it just in a few minutes in details, okay? So let us continue. So we have effects of tumor on host. So location is crucial in both benign and malignant tumors, and that is quite obvious. The location of that tumor is always very important for the growth of the tumor because remember, it can influence things like perfusion of the tumor. And honestly speaking, you guys by now know that a tumor can only grow past 1 to 2 millimeters in case it has a blood vessel supplying nutrients, okay? And that's why we have neovascularization through things like the insulin-like growth factor, the fibroblast growth factor, and even things like the platelet-derived growth factor. They're very important in neovascularization for formation of new blood vessels to supply nutrients to the tumor, okay? So a small, about 1 centimeter pituitary adenoma can compress and destroy the surrounding normal gland, okay? That's quite obvious. You guys talked about the origin of the development process of the pituitary gland, the anterior pituitary gland and the posterior. And we said that the anterior usually comes from the Rathke's pouch, the pharyngeal epithelium outpouch, and we said that the posterior or the neurohypophysis usually arises from maybe just a continuation of the hypothalamus, yeah, into the it is basically like a neuronal tissue elongation from the hypothalamus gland that leads to the formation of the neurohypophysis. That's why it is called neurohypophysis. Okay. Then you have also a leiomyoma, okay, in the wall of the renal artery. They may encroach on the blood supply, leading to renal ischemia and hypertension. And that's why we say that one of the hallmarks or one of the effects is maybe they can lead to infarction or even rupture of a blood vessel. And that one can be seen on a leiomyoma in that it can lead to renal ischemia and hypertension, okay? So a comparably small carcinoma within the common bile duct may induce fatal biliary tract obstruction. So we know the common bile duct is very important for the for conveying bile, right? So in case you have a tumor that is blocking it, maybe a small carcinoma, we can have the blockage of that particular bile duct, and this one can be very fatal. It can even lead to jaundice, and you guys know the mechanism of jaundice formation, okay? When we have signs and symptoms related to hormone production are often seen in patients with benign and malignant tumor arising from endocrine glands, and I think I've mentioned that, right? So I won't repeat that again. And I say that a tumor arising from an endocrine gland is called an adenoma. That's very important. But again, remember, you can have a tumor arising from an endocrine gland, but it assumes a glandular pattern. The same tumor will be called an adenoma. So this adenoma can be used in two cases, a tumor arising from an endocrine gland or a tumor that resembles an endocrine gland in terms of the glandular structures, but it doesn't arise from a gland. So it's also called an adenoma. Maybe you can talk about a condition called hyperinsulinism, which I've also mentioned. In case you have a benign tumor of the isolates of lung and specifically the alpha cells, you can have an insulinoma, which can lead to hyperinsulinism, okay? And then sometimes might be soft fatal. You guys know the physiology of insulin and glucagon, and you know what can happen in case you have hyperinsulinism. The patient can actually be at a very increased risk. Yeah. Then you also have the same concept with aldosterone. In case you have a tumor, which can lead to increased production of aldosterone. You guys have talked about things like the Conn syndrome, we have the pheochromocytoma, you know, the effects of those particular types of tumor, right? And whenever we have an increased aldosterone, we can basically lead to increased sodium retention because, you know, aldosterone will act on can even act on the principal cells of the distal and the collecting tubules to increase reabsorption of sodium ions at the same time, increasing the secretion of potassium ions. So that's what will lead to hypokalemia, okay? But it will lead to hypertension because remember we are taking a lot of sodium inside the plasma. So this will draw in water, which will lead to hypertension. Okay. Yeah. So such hormonal activity is more likely with a well-differentiated tumor. And I say that this thing is usually commonly seen in benign tumors, especially adenomas. Okay. And adenomas are usually well differentiated, while malignant tumors are usually not well differentiated. They are poorly differentiated, and a common hallmark for them is usually anaplastic cells formation. That is one of the hallmarks. And by now, you know that for you to identify an anaplastic cell, you need to look for at least 6 features. Let me just try to recap them quite quickly. We have number one, you can look at giant cells or giant tumors. You can look at atypical mitosis. Okay, you can look at a lack of polarity. You can look at the nuclear to cytoplasm ratio. Normally, it is usually 1:6 or 1:4. But for a patient maybe who has a malignant tumor, when you look at a sample of the anaplastic cell, you'll see that the ratio can even be around 1:1. In short, the nucleus will grow to be a little bit big, okay? So that's one of the hallmarks again. Then again, you can look at pleomorphic cells. The cells are pleomorphic, they're different shapes. Then again, we can have dark staining cells, yeah? We can have dark staining cells. Those are some of the hallmarks of an anaplastic cell, okay? So benign or malignant neoplasm that protrude into the gut, lumen may become caught in peristaltic pool of the gut, causing interception and intestinal obstruction or infarction. You guys can think about a polyp. Yeah, a polyp. A polyp can be one of an example that can also predispose this patient to gastric obstruction. And a polyp, we'll talk about the APC pathway, things to do with beta-catenin, and I think we'll understand much better about the pathogenesis and how these polyps usually arises here. So let us go to cancer cachexia. So many cancer patients have a progressive loss of body fat and lean body mass, accompanied by profound weakness, anorexia, and anemia, a condition called cachexia. So when you look at a cancer patient, most of them, my mom was a victim, but when you look at them, you find that they usually have profound weakness. They can even have anorexia, they can have anemia. Yeah, that's what we basically call cachexia. So we want to look at the mechanism at which this arises, basically by the cytokine-mediated pathways, okay? So although patients with cancer often are anorexic, and I hope you know the meaning of anorexia, current evidence indicates that cachexia results from the action of soluble factors like cytokines, especially tumor necrosis factor. We'll see how that happens, okay? In patients with cancers, calorie expenditure remains high and a basal metabolic rate is increased despite reduced food intake, okay? When we look at a patient suffering from cancer, these patients, some of them don't have appetite, they don't eat a lot. But when you look at the basal metabolic rate, the BMR is usually still increased, okay? And this one will actually mean that the calorie expenditure will also remain high, despite them having reduced food intake. So this is a bit paradoxical, right? So this is in contrast with the lower metabolic rate that occurs as an adaptive response to starvation. So when someone is starving, we expect that the BMR will go low, yeah? But for cancer case, it's actually the opposite. So it's a bit paradoxical. So we need to understand how this happens, okay? But remember, the basis of this is usually not well understood. It's not well understood, okay? But it is suspected to be mediated by a cytokine-related pathway, especially TNF, and maybe other cytokines, but I want us to focus on TNF. You know, the meaning of TNF is tumor necrosis factor. It was given this name because it was thought to be killing tumor cells. That's what we call tumor necrosis. Necrosis, we talked about necrosis, apoptosis, pyroptosis. We talked about necrotosis. So you can imagine tumor necrosis factor, what it can do to a tumor cell, okay? So TNF usually suppresses appetite and inhibits action of lipoprotein lipase, yeah, LPL. preventing the release of free fatty acid from lipoprotein. So this enzyme is very important for this free fatty acid from lipoprotein, okay? So remember, there's no satisfactory treatment for this cancer cachexia, okay? There's no satisfactory treatment of this, but maybe you can just solve it by removing the underlying cause, which is basically a tumor, but we can't actually treat this cachexia, this cancer cachexia. So that's a brief about this cancer cachexia. I hope you have gotten something. A very important point is that it is mediated by TNF, that is very ideal, okay, or by cytokines. And it is paradoxical in that the BMR is increased even though the patient is not taking a lot of food, okay. So let us go to paraneoplastic syndromes, okay. So these are symptom complexes that occur in patients with cancer and that cannot be readily explained by local or distant spread of tumor or by elaboration of hormones indigenous to the tissue of origin of tumor. And this is what we call paraneoplastic syndromes, okay. So they usually appear in around 10 to 15% of patients with cancer. And their clinical recognition is usually important for several reasons, okay. So these paraneoplastic syndromes are not common in every cancer patient, but they occur in around 10 to 15% of patients. So it's basically a very important thing to consider because 10 to 15% of cancer patients is not a small number. Now, there's so many people diagnosed with cancer and so many people perishing because of cancer. Yeah, so even in our current population, even in Kenya, you can find that there are so many people who have cancer. So when you take 10% of this population, it can give you a very complex amount of persons. So it isn't something that you should take lightly, okay? Yeah, but the clinical recognition is an important one because such syndromes may present the earliest manifestation of an occult neoplasm, occult, maybe basically a malignant neoplasm, okay? Then in affected patients, the pathological changes may be associated with significant clinical illness and may be lethal, okay? So in patients who have these paraneoplastic syndromes, we can have some pathological changes, okay? And this one can be very significant in terms of clinical illness and may even be lethal, okay? Then the symptoms may even mimic metastatic disease. Yeah, they might mimic metastatic disease and therefore confounding treatment. So these are the three important points that you need to know about the recognition of these particular paraneoplastic syndromes in terms of their importance. Okay. So let us go to the most common neoplastic syndromes are usually hypercalcemia, Cushing syndrome, non-bacterial thrombotic endocarditis. So maybe just to highlight them, Cushing syndrome, hypercalcemia, and bacterial thrombotic endocarditis. And the neoplasm most often associated with this and other syndromes are lung and breast cancers and hematological malignancies. So importantly, know that most of the paraneoplastic syndromes are seen in lung, breast cancers, and hematological malignancies, okay? And the syndromes associated with these types of cancers can even be hypercalcemia, Cushing syndromes, and bacterial thrombotic endocarditis. These are the most common syndromes in paraneoplastic syndromes, okay? So let us look at hypercalcemia. In cancer patients, it is multifactorial, okay? But the most important mechanism is the synthesis of a parathyroid hormone-related protein. Okay, this is basically a receptor by tumor cells. So the PTH will come and bind to this receptor, and this receptor is actually expressed in tumor cells, okay? You guys know the function of parathyroid hormone. Parathyroid hormone is usually secreted. It is a primary hormone for increasing calcium ions, especially in serum, in case the levels of calcium go down, okay? So this parathyroid hormone will bind to the PTHRP, and this one is usually expressed by the tumor cells, okay? And again, it has also been implicated in tumor-derived factors like the transforming growth factor alpha, and even the active form of vitamin D, that is 125, the dihydrocholecalciferol, are produced majorly in the kidney, okay? Another possible mechanism of hypercalcemia is widespread osteolytic metastatic disease of the bone. From the name, it is osteolytic. Lytic lysis means breaking down by using enzymes like proteases and even enzymes from the lysosome. So when you break the bone matrix, you kind of like be releasing even the calcium ions that are very important information of the calcium hydroxyapatite, which strengthens the bones basically. So when you break the entire thing, the bone mass will be releasing calcium. So it means that in patients who have osteolytic metastatic bone disease, again, you can have hypercalcemia, okay? So of note, however, hypercalcemia resulting from skeletal metastasis is not a paraneoplastic syndrome. Note that. Let me repeat. Hypercalcemia resulting from skeletal metastasis is not a paraneoplastic syndrome. Okay, that's very important. Then Cushing syndrome arises as a paraneoplastic phenomenon, Usually, it's related to ectopic production of ACTH or ACTH like polypeptides by cancer cells. Remember, ACTH basically is produced from the pituitary gland, right? But you can have an ectopic production of ACTH by a tumor that is not related to the anterior pituitary gland. Maybe this tumor is located somewhere in the lung, okay? So this will lead to increased production of ACTH. And that is what we're talking about, a paraneoplastic syndrome. Paraneoplastic, para, it means that it is not in the organ that is known to produce that particular hormone, okay? For example, you can look at the Cushing syndrome due to excessive ACTH, which will go and lead to excessive production of cortisol. But the tumor producing this ACTH might not be in the anterior pituitary gland, but rather it can even be in the lung, somewhere in the lung, okay? For example, the small cell carcinoma of the lung is a very common one in terms of producing ACTH. So that is what we call a paraneoplastic tumor. It is producing an hormone, but it's not supposed to be produced by that organ. Okay, I hope you have gotten now the point. So these types of syndrome can also manifest as hypercoagulability. Okay, and I think we tackled hypercoagulability during thrombosis, the Vicos triad. It was one of the contributing factors to thrombus formation. And then can lead to venous thrombosis, yeah, because you know that it can cause thrombosis, hypercoagulability, coagulation factors are so elevated in plasma. So this can predispose the patient to a lot of venous thrombosis. And you know that whenever we have a deep venous thrombosis, DVT, you can have embolus formation, which can be carried by the inferior vena cava to the heart, and this one can move to the lungs, the pulmonary arteries, and block them. So these patients can manifest with pulmonary edema, okay? And again, we can have non-bacterial thrombotic endocarditis. Yeah, remember we can also have bacterial thrombotic endocarditis. So again, these ones can be seen in paraneoplastic syndromes, okay? So other manifestation can be clubbing of fingers and hypertrophic osteoarthropathy in patients with lung carcinomas. That's also very high yield. And I think I'll just give you a table so that you can appreciate whatever I'm talking about, okay? So we also have a particularly devastating form of paraneoplastic syndrome, and this is usually called paraneoplastic neurological disorders. From the term neurological, you can see it is a tumor that is affecting the central nervous system, and it can also affect the peripheral nervous system, okay? So the incidence usually varies the incidence of PNS varies with the neurological syndrome and with the tumor, okay? So remember that when you have this paraneoplastic neurological syndrome, it can be so devastating because when you affect the central nervous system, you know, this patient can really die quite quickly. That's why when we have a case of a brain tumor, we really need to be so vigilant in treating that particular tumor, okay? So these are just very many details that I don't want to talk about, and I think most of them you have covered. I just want us to focus on this table. Don't worry so much about this information here. Yeah, if you can get these slides later on, you can just take your time to go through them because I don't think if they're so important. But I want us to accent on this table here. So we have endocrinopathies, and we can have Cushing syndrome. Remember, we're talking about a paraneoplastic syndrome, right? And I told you that a paraneoplastic syndrome basically is a tumor that is in another organ like the lung, but it's producing an hormone that is supposed to be produced in another organ, okay? And I think we talked about ACTH produced by the small cell carcinoma of the lung, but ideally, ACTH is supposed to be produced by the anterior pituitary gland. So maybe we expect maybe a tumor of the anterior pituitary gland to be producing a lot of ACTH, but not a small cell carcinoma of the lung. But again, it is paradoxical in that it is true that a small cell carcinoma can produce ACTH. So for Cushing syndrome, you can have major cancers like the small cell carcinoma of the lung. You can have even the pancreatic carcinoma and the neural tumors. All of them can produce ACTH and they can even lead to elevation of cortisol. So the cause mechanism is basically by producing ACTH or ACTH-like substance. So remember the three types of tumors here can lead to production of ACTH or ACTH-like tumors. Then you have syndrome of inappropriate antidiuretic hormone secretion. So you can have small cell carcinoma of the lung, and you can have intracranial neoplasm. Okay, so the two of them can lead to this syndrome of inappropriate antidiuretic hormone secretion. And how do they work? They basically work by producing ADH, okay? And even the ANP. ANP is usually produced when you have an atrial stretch due to maybe hypertension, and also have the brain natriuretic peptides or hormones that are usually produced from the ventricular and the stretch. So know the difference between the two of them. Then you have hypercalcemia, we have talked about it. Number one, you can have small cell carcinoma of the lung, we can have the breast cancer, we can have renal carcinoma, and adult T-cell leukemia or lymphoma. I think we talked about this one when we're talking about the oncogenic viruses, especially HTLV1. We say that basically all of these are mediated majorly by the TAX gene and even the HPZ gene, okay? And we said one of the ways in which you can have these lymphomas and proliferation of B cells is by the nuclear factor kappa beta, which is very important in terms of preventing apoptosis and increasing survival of cells, okay? What about the cause of mechanisms? I want you to really be so careful on this because it's an examinable part, okay? So hypercalcemia is usually mediated by the parathyroid hormone, okay? Through the receptor that I've talked about, the parathyroid hormone-related protein, the PTHRP produced by the tumor itself. Then you have the transforming growth factor alpha, and you have the tumor necrosis factor and interleukin-1. These are very important in hypercalcemia formation as a clinical syndrome of a paraneoplastic tumor. But remember, we can't have something like a fibroblast growth factor here. It can't actually work here. These are the four major ones that we see in hypercalcemia. What about hypoglycemia? We can have an ovarian carcinoma, we can have a fibrosarcoma, and other mesenchymal sarcomas. And how is this possible? It's basically by producing insulin or insulin-like substance, okay? So this is what will lead to hypoglycemia. Because remember, insulin basically is supposed to reduce the blood glucose level, especially after taking a heavy meal of carbohydrates. And it does that by increasing glucose uptake into the cells. Then we can have a carcinoid syndrome, for example, hepatocellular carcinoma. We can have bronchial adenoma, which is a carcinoid. We can have pancreatic carcinoma. How do they do this? Basically by producing serotonin and bradykinin, okay? Then you have polycythemia. We have polycythemia vera, basically increased production of RBC in blood. It's a type of a cancer, though it's a malignant thing. So what are the types of tumors that can lead to this polycythemia? We can have gastric carcinoma, we can have renal carcinoma, we can have cerebellar hemangioma, and we can have hepatocellular carcinoma. And how do they do this? They do this through erythropoietin, EPO. EPO is majorly produced by the kidney. That's why we have a renal carcinoma somewhere here, okay? Because it's majorly produced by the kidney, okay? So these are some of the examples of paraneoplastic syndromes. Take your time to understand this table, to know the type of tumors that lead to different endocrinopathies and the causative mechanism in terms of the hormones involved and even the receptors involved. But I see that I have a lot of emphasis, I put a lot of emphasis on hypercalcemia, these types of cancers that I talked about, squamous cell carcinoma, breast carcinoma, renal carcinoma, and adult T-cell leukemia. And I said that you need to understand these four. Okay, this receptor for parathyroid hormone, the transforming growth factor, alpha, the TNF, and the interleukin-1. They are very important in mediating hypercalcemia in paraneoplastic syndrome. But I warned you that we don't have something like a fibroblast growth factor here, so take note of that. Okay, I hope that's well understood. So this basically is still a table showing those paraneoplastic syndromes. I want to go through it because we have covered so much in the previous slide, okay? But remember, paraneoplastic syndrome is a wide thing, so you can just take your time to go through different sources, especially in PubMed, NCBI. You can use your books like Robbins Pathology, just to get diverse knowledge about this paraneoplastic syndrome, because it is not just limited to whatever I've taught you, but it is something wide that you're supposed to know, okay? So I won't talk so much about this short. Yeah, so let us talk about grading and staging of tumor, okay? So methods to quantify the probable clinical aggressiveness of a given neoplasm and its apparent extent and spread in individual patients are necessary for arriving at an accurate prognosis and for comparing end results of various treatment protocols, okay? So these are just a lot of information that want to be so important. So I won't take my time to go through all this because they're not so important, okay? But you can take your time to just go through them, okay? Well, I just want us now to go to the difference between grading of tumor and staging of tumor. So let us look at grading of tumor. So grading is usually based on the differentiation of the tumor, not that. Grading is usually based on the degree of differentiation of the tumor, okay? And in some cancers, we can even have a number of mitosis and the presence of certain architectural features, okay? Note that is very important, by the way. Grading is usually based on the degree of differentiation of the tumor, okay? So grading schemes have evolved for each type of malignancy and generally range from two categories. You have low grade and high grade, okay? To 4 categories. I think we'll just mention that as we go along, okay? So criteria for individual grades may vary in different types of tumors, but all attempt in essence to judge the extent to which the tumor cells resemble or fail to resemble their normal counterparts. So when you introduce the oral concept of neoplasia, we said that differentiation is basically talking about the resemblance of a tumor to the organ of origin, okay, which was healthy. I hope that's very clear, okay. So this grading basically is just meant to show the correlation between this tumor and the organ of origin in terms of their resemblance, okay, to their normal counterparts, okay. So although histological grading is usually useful, the correlation between histological appearance and biological behavior is less than perfect. That's true, okay. You can look at an histological view of a tumor, for instance, um, but the biological behavior of this tumor is totally different. Let me give you a good example. We have the basal cell carcinoma. Basal cell carcinoma can be a very large tumor, but it doesn't spread so much. It is not so invasive. It is not so metastatic, okay? So when you look at the histology for basal cell carcinoma, you can see a lot of things like anaplastic cells and everything, but the biological behavior of this tumor is less than perfect. It doesn't reflect the histological view of this particular tumor, okay? That's what this particular statement is trying to talk about, okay? In recognition of this problem and to avoid spurious quantification, it is common practice to characterize a particular tumor based on the descriptive terms. For example, a well-differentiated mucin-secreting adenocarcinoma of the tumor, or a poorly differentiated pancreatic adenocarcinoma, okay? So basically, we normally prefer to now describe these particular tumors in this way. Why? Because you can have a poorly differentiated pancreatic adenocarcinoma. So you need to actually specify. For example, you can say a well-differentiated mucin-secreting adenocarcinoma. A well-differentiated. So because it's well-differentiated, it is benign. And I said benign tumors can produce hormones. They can still secrete a lot of secretions, like even digestive diseases. Okay. So you can say a well-differentiated mucin-secreting adenocarcinoma. You need to specify because you can have a well-differentiated non-mucin producing adenocarcinoma. So basically, you need just to specify so that it can be well known to the person who is actually going through your report. So we have grade 1, grade 2, grade 3, grade 4, well differentiated, moderately, poorly differentiated. I want to go through this because these are quite obvious. Let us go to staging of cancer, which is the most common thing in our country and also in the world at large. And staging of cancer is very diverse, okay? So the staging of solid cancers is based on the size of the primary lesion, its extent of spread to regional lymph nodes, and the presence or absence of blood-borne metastasis. So this is very important in our clinical practicing, especially when maybe someone is doing oncology, okay? So the major staging system currently in use is the American Joint Committee on Cancer Staging. And this system uses classification based on the TNM system, T for primary tumor, N for regional lymph node involvement, and M for metastasis. So remember that TNM, T for primary tumor, N for regional lymph node involvement, and M for metastasis, okay? So TNM staging varies for specific forms of cancer, but the general principles, okay? They vary for different types of cancers, but they are general principles, they're general, okay? So the primary lesion is usually featured as T1 to T4, and this one is usually based on increasing size, okay? So it means that when I say TO, okay, TO means that the tumor is in situ. It hasn't yet started even to metastasize, it is in situ. But the moment I say T1 to T4, someone can click on your head. It's a primary tumor, but this one is basically describing the extent of lesion of that primary tumor, okay? Then when we go to the lymph node involvement, that is N, we can have NO, and NO means that we don't have any nodal involvement. N0, 0 means nothing. So basically no nodal involvement. But when you talk about N1, N3, this one will denote the involvement of increasing number and range of lymph nodes, okay? So from N1 to N2, we have increasing number of lymph nodes that are being involved in this particular metastasis. Then you have MO, we say that M is for metastasis. So when I say MO, it means that we don't have any metastasis. At the moment I start from M1, going onwards, you can say that we have different degree of metastasis. So I hope you have understood how these things are staged in terms of the primary tumor, in terms of the lymph node involvement, and in terms of metastasis. Remember, malignant tumors usually metastasize, but not benign tumors. I think that one now people know. So what is cancer staging, okay? Staging is a way of describing how much a cancer has grown and spread. So staging is very important because it will not only talk about the size of the tumor, but again, it will try to elaborate the spread of the tumor, okay? A common way for staging cancer is the TNM classification. I think I've talked about that one, okay? Where T stands for the tumor, okay? Alpha, the primary tumor has grown locally. So T is for primary tumor, the growth of the tumor, the growth of the primary tumor lesion. Then N stands for the lymph nodes. We talked about the lymph node involvements. Then M stands for metastasis, okay? So if the cancer spread to other parts of the body, this TNM classification is very important to show which grade, which stage of cancer this is, okay? So when a cancer is staged, a number is usually given for each of the three classifications. And this one was just to show you how this is done. But I just want you to maybe go through different sites and learn a bit more about this staging of cancer. So you can have T1. This means primary tumor is still on the stomach wall. So maybe you are using an example for stomach cancer. So when I say T1, it means that this tumor is in the stomach wall. But when I say T3, it means that this tumor has grown right through the stomach wall and has even spread to nearby features. But now when I say stage 4, T4, it means that this cancer is now invading many organs around it, like the pancreas. You can even talk about the lungs. They're being invaded by this particular tumor. So that's T4. So you can appreciate the degree of this primary tumor spread in terms of T1 to T4. I said when I say N1, I mean we don't have any lymph node involvement, but when I say N1, we have local lymph nodes that are affected. But when I say N2 now, N2 means that we have a more extensive spread to local lymph nodes, okay? I said MO means no metastasis, but the moment I say M1, we now have a metastasis, okay? So for example, for a certain stomach cancer, a doctor may say something like, the stage is T3, N1, and MO. So what does this one mean? I think from our preceding discussion, you can already explain whatever this one means. So it means that the cancer has spread through the stomach wall. Okay, you can even use this information here. It has spread through the stomach wall. And N1 means that there's some spread to the local lymph nodes. And I think that's what you said here. There's some local spread to the local lymph nodes. So that's what N1 means. And MO means that there's no metastasis. So this can be a very good news to the patient, because if you don't have metastasis, something can be done to help the patient. Not just palliative care though, but we can do something maybe to help this patient. So that is what we can interpret an information. When you're being told T3 and 1 MO, now you can think about something, okay? I think we have talked about that one. So there are other staging classifications which are sometimes used for various cancers. For example, cancers, not cancers, I'm sorry. For example, a number system is used for some cancers. That is, a cancer may simply be said to be stage 1, 3, 2, 4, or stage Roman 1, 2, 3, 4. Again, the stages reflect how like the primary tumor has become and whether the cancer spread to local lymph nodes or other areas of the body, basically metastasis. It can become complicated as each number may be subdivided into A, B. We can even have stage 1A, 1B. So it can be a bit complicated. I remember my mom, us was using these alphabets, like we had 1A, 1B, something like that. Yeah. So for example, you may have a cancer at stage 3B. A grade 4 is often referred to as an advanced cancer. So basically, that's all about paraneoplastic syndrome and cancer staging. But these are some of the sources of information that you can go and look at. They can give you some good amount of information. You can use Robin's basic pathology. It's called basic because it just give you a rough idea. Then you can maybe check NSBI. You can check these cancer sites to get some information if you're interested in these things. Okay. But remember, the importance of staging is basically to help in treatment, in that when a patient is in stage 4 cancer, that patient is going to die, so you just need to do palliative care. But when the patient is in stage 1, something can be done to help the patient in terms of surgical excision and just many other therapies that can be done. So I'm done with this presentation. But for this presentation, you guys, you need to go and check these different sources that I've highlighted here so that you can grow your content here. So that's it.